Dr. Sachin Matthew sir, who will be speaking on atypical microbial keratitis. Dr. Sachin sir has been working at Chaitanya Eye Hospital, Palarivettam, and Jyoti's Eye Hospital, Kannur.
Yeah, good morning. Good morning, everyone. Thanks to Dr. Reshmi for inviting me for this IC actually. So why atypical microbial keratitis? It's because these are infections caused by microorganisms which are not commonly encountered in clinical practice actually, because it is usually associated with worse outcomes. Why? Because by the time we get a diagnosis, it will be quite late. Prognosis is also pretty bad, because the standard diagnostic procedures which was discussed, usually will come as negative. So this results in a delay of the initiation of appropriate techniques, and there is limited literature also on these management strategies of some of these conditions. So that makes it very difficult to treat. Now, that is what we need to, for treating these kind of conditions, we need a high index of suspicion. Like if the organism or the disease is not responding to your treatment, then you should start thinking about the history. Did he have a history of travel to countries where these things are common, or there is a recent corneal surgery or a laser refractive surgery or a trauma from soil or vegetative matter? Does he have a, immune compromised state? So basically, this needs a little bit of clinical acumen and a high index of suspicion, because by the time we come to a diagnosis, the time is the key. It will be a little delayed. So I'm going to just discuss about, there are a lot of, there's a gamut of infections, but I thought I'll discuss something a relatively common, microsporidia to atypical mycobacteria, nocardia, and pythium. Pythium was discussed by my previous speaker before. So microsporidia, why it is important is because it is extremely, sometimes it looks almost similar to viral. It is a spore-forming obligate protozoan from the family Microspora, and it's commonly spread through contaminated water. So that is the first high index of suspicion you should have. If you have a unilateral infection which looks like viral, and if it's got some kind of attachment to a contaminated water, you should start thinking about microsporidia. A treatment is relatively simple. You can just put fluoroquinolones with or without a combination of imagilin or albendazole. And most of the studies say is 99% of resolution with monotherapy of fluoroquinolone. Sometimes epithelial debridement will be easier. If you can resolve the disease. This is one of the case reports which came in IGO recently. This is the typical picture of a unilateral microsporidia. It will be unilateral, and the typical picture is like this: the multifocal fine to coarse stuck-on epithelial lesions on the cornea. And here they did a KOH-1, and they just put a KOH-1 and they found this microsporidial bowl. So, why they thought about this is because of that, normally we would start treatment as a viral, but that unilateral thing and the contaminated water, that history was the key. This is another case which was published in JAMA actually, and this is a 65-year-old gentleman with that central area of stromal infiltration. This looks like a typical disciform keratitis. He would have started treatment, and they also started treatment as a viral with prednisolone, and then by the time it started tapering, it became the second picture. The central epithelial defect with pannus, and ultimately it perforated. We had to do they had to do a keratoplasty, and only the keratoplasty button they could identify the microsporidia. So I think microsporidia it's all about your high index of suspicion and start thinking about it. You can do a lissamine green staining and finding out microsporidia, but at least start the treatment in a different way. Now coming to AMK or atypical mycobacteria, this is a little more common in, it was common initially in post-LASIK cases. This is a non-tuberculous mycobacteria, usually it's Mycobacterium fortium and Kilone. And as I said, there should be a breach in the corneal epithelial layer for this thing to enter the cornea. So that is the key. So you have a LASIK, post-LASIK, corneal sutures, foreign body, contact lens wear. So these are the histories you should look for to think of atypical. Because unless otherwise we tell the lab technician to look for these things, they will never look for this. You have to do Ziehl-Nelson stain. So not the usual pattern. So that is why we have to have a high index of suspicion, as I said. The lesion is usually the cracked windshield appearance, lesions with the irregular edges, ring infiltrates, multifocal or satellite lesions with infectious crystalline keratopathy. The treatment, usually amikacin is the drug of choice, but although they have, we can combine the medication with macrolides like clarithromycin, azithromycin, or fourth generation fluoroquinolones. Coming to nocardia, nocardia is again, thankfully, it's very rare. Again, the suspicion of, you have exposure to soil, mud and decaying vegetation, you should start thinking about it, and it's not responding. This clinical picture is classical. You have a wreath-like pattern with patchy, raised, pin-sized infiltrates. And you will, in the light microscopy, you will see gram stain showing gram-positive bacteria with beaded filaments. That's why initially it was thought about as fungi actually. Amikacin is the drug of choice, and second-line agents is gentamicin and tobramycin and trimethoprim. More important is to get a diagnosis of nocardia, then only we can start the treatment. Pythium is relatively rare, and mostly it's rare because we are not identifying it. It's a fungus-like organism. Like this study in British Journal, there was a lot of unidentified fungi in, that may be attributed to this Pythium. Pythium insidiosum is the common one, and it's seen as hyphae and zoospores. And the hyphae is actually lengthier, but this is all for microbiology. I don't think normally we can differentiate a Pythium hyphae and a fungal hyphae. But the culture shows the zoospore induction. Again, the clinical picture, you can see this classical tentacle or reticular-like radiating extensions from the limbus. But the thing is, by the time we come to a diagnosis, it will be like the second picture, and you'll have to do a keratoplasty. Again, the treatment is pretty tricky. There is no algorithm for this, but it's based on large studies. Bagga et al. Has the largest study. Actually, it was published in British Journal in 2018. He had a case series of 144 patients. It responded to a combination of topical linezolid, azithromycin, and oral azithromycin. Another study from Agarwal's group, they said medical therapy was not so good, and all corneal infiltrates larger than 8 mm was responded to therapeutic PK. Some of them responded to the cryotherapy combined with an alcohol applications. So this is actually, I suggest reading of this actually. It's a study from Singapore group with Namrata Madam actually. It was published in Ocular Surface. It gives the gamut of infections. Thank you.
So I think we have the luxury of 4 minutes for discussion. Thank you, Sachin, for finishing.